Hello, everyone. I'm Bernice Jordan, one of the public health program managers at USET. This presentation is our behavioral health track. Our session will be focusing on cultural integration process in a mental health setting. I would like to introduce our presenter, Melanie Cain. Dr. Cain is from Santa Clara Pueblo and Hicora Apache tribes in northern New Mexico. She is a licensed psychologist and mental health clinical program manager with the Los Angeles County Department of Mental Health at the American Indian Counseling Center. She works part-time with a Conscious Culture Psychology Clinic. She graduated with her PhD in counseling psychology from Oklahoma State University in May 2007 and is currently pursuing a Master's of Public Administration through California State University, Northridge. Prior to her work with Los Angeles County, she worked at the San Diego American Indian Center, where she provided therapy and served as the project coordinator for the first urban American Indian Youth Center, supported by San Diego County Prevention and Early Intervention. In addition to her experience with psychology, Dr. Cain is a veteran of the United States Air Force and is proud to say she comes from 3 generations of Native American women whom have enlisted in the armed forces. Without further ado, please share your screen, Dr. Cain.
Thank you. Good morning, everyone. Let's see. Is everyone able to see that?
Yes.
All right. So good morning, everyone. My name is Melanie Cain. I will be talking today about cultural integration, primarily within the American Indian Counseling Center. And I'll provide some background of the clinical setting and some of the work that we've done, including some of the strengths and some of the challenges. And I will go ahead and take questions during this. So please feel free to speak up, raise your hand, and we can make this a discussion type presentation. So the purpose of this presentation is to explore cultural integration within a westernized clinical setting by highlighting incorporation of cultural knowledge into the workflow, discuss the importance of assessment and inclusion of community-based needs into clinical practice, and discuss the importance of team processing in the implementation of changes. And before we begin, I would like to, let's see my screen, pay respect to the original people through a land acknowledgement. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. This presentation is taking place on the ancestral lands of the Tongva people. We pay respects to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. So let's see, and I know you all are in Tennessee or all over New York. All right, so these are pictures of just different places that healing ceremony and gathering take place. I'm Pueblo, and when I've participated, during childhood in some of our traditional ceremonies, they took place in the kiva, and that's where the community gathered. That's where the prayers took place. That's where we prepared, and that was the center of the healing. Other cultures and communities use sweat lodges as places to gather and to pray and to have that collective unity, again, in healing and strength. And other methods used are talking circles. And these are all, cultural traditional methods. And then I've included a picture of the American Indian Counseling Center, which is where I work, which is, it's still a place of healing. It's still a place of ceremony and gathering. However, we can see that the structure, it's very different. It's in the middle of a city. It's not traditional or cultural, maybe traditional in the Western method, but that's one of the areas that I'd like to highlight. So the Los Angeles County Department of Mental Health is one of the largest mental health providers in the country. The mission of DMH is to optimize hope, well-being, and the life trajectory of Los Angeles County's most vulnerable through access to care and resources that promote not only independence and personal recovery, but also connectedness and community reintegration. Services are provided for community members throughout Los Angeles County. There are specialized programs like in the jails, working with the homeless population, working with children in Department of Children and Family Services. There are directly operated programs, which is what the American Indian Counseling Center is. And there are also legal entities which have contracts with the department. So the department is this huge umbrella, and stakeholder involvement is one of the methods that the department uses to engage the community. One of these groups is the Underserved Cultural Committee. The American Indian and Alaska Natives do have a Underserved Cultural Committee that meets 1 to 2 times a month to talk about different projects that may be coming up or different funding opportunities, and also to discuss different events happening within the department. The Mental Health Commission also meets monthly, and this can include community members as well, and also the Service Leadership Team, which meets again on a monthly basis to talk about different programs that are coming up within the department. And the American Indian Counseling Center is a directly operated division within that larger department. The clinic was established in 1987 after several community members advocated for the need for mental health care unique to Native Americans in Los Angeles County. And this, was a process, but it wasn't something that was initially thought of within the department. We are fortunate because the staff that do work at the agency, they are either American Indian or Alaska Native themselves, or they have working experience with the Native American community. So they have some understanding of what it means to provide mental health care to the Native people. And we do provide field-based services. This means we are, pre-COVID, we were all over Los Angeles County. So I don't know if any of you have been here, but it's pretty large. And our clinicians and our staff can go anywhere in the county to provide care because our community is spread out. And one aspect that does influence the care we provide is the building is shared with 2 other clinical programs. So one of these clinical programs is also a directly operated mental health program, which has about 3,000 to 4,000 clients. And then there's also the crisis-based field response program. So it can be challenging to have space or to, maybe have a drum group, because if we had a drum group, let's say at 3 o'clock, 2 o'clock in the afternoon, it could be pretty loud and possibly disruptive to other programs in the building. Some of the specific programs that we do have in our clinic are a birth to 5 program. This program is led by a psychologist who specializes in working with this population. We have specialized foster care program, which works with children or parents who may or may not be involved with Department of Children and Family Services. Children's Wellness Center, which is focused on groups and activities to promote wellness, prevention and early intervention, recovery, resilience, and reintegration for adults, and full service partnership. So again, we see clients of all ages, all varied levels of diagnosis. Some of the services we provide are individual therapy, group therapy, case management, medication support. We do have a psychiatrist who's Alaska Native, which really helps some of our clients because they feel more comfortable talking to him. We also have a preventive medicine physician, and we do provide crisis response. In addition, we collaborate and work to form partnerships with other community-based agencies serving the community. And the Native population in Los Angeles is one of the highest in the country. These statistics might be outdated a bit. However, we know that 71% of Native people live in urban areas, and Los Angeles is home to one of the largest populations. There are 3 tribal nations indigenous to Los Angeles: Gabrielino, Tongva, Fernandeño, Tataviam, and Chumash. However, there are also more than 100 tribes in Los Angeles, although they may not be federally recognized. Some of the clients we see, they range. You know, we might see a client who is starting college and maybe experiencing anxiety associated with college experience. Or we may see someone who has been homeless for 25 years. Some of the diagnoses which are most prevalent are depressive disorders, bipolar disorders, and schizophrenic disorders. Probably about, I would say maybe, I don't know, almost 10% of our population is homeless. However, we are able to link them with vouchers and housing services, shelters, dual diagnosis. A lot of our clients have, may have like a substance use issue. A lot of our clients smoke, so we will be starting a smoking cessation program. We do have children who are involved with DCFS, and also multi-generational. Sometimes it's not uncommon to have worked with a parent, and then 5 or 10 years later, their daughter comes in, or their son, and then their grandchild comes in. So you get to know the families, and also various cultural identity and knowledge. We have some clients who were born and raised in Los Angeles. We have clients who may have come to Los Angeles during the relocation period, and still know, you know, what it means to live on the reservation or live in their tribal lands. We also have clients who may be visiting friends or family from back home, clients who come in for treatment who may be in Los Angeles for the first time. You know, I've seen clients from Santa Clara Pueblo, and they come to Los Angeles, so it's a culture shock. It's a complete different type of environment. Are there any questions so far? No, okay. I'll go ahead and keep going. Part of our process of cultural integration, I was looking at it from the beginning. You know, in the beginning, when the clinic first started, there were 2 Native clinicians. They were located in Hollywood, and they were responsible for serving all of the Native people in Los Angeles County. So now we have about 15 clinicians. I would say at least half of our staff are Native American or have some experience. Some of the ways that we've included cultural integration is by providing a welcome packet, which explains historical trauma, it talks about healing, has information on balance and the medicine wheel. You know, some people use that, and that's been helpful for some of our clients. Other activities have included having drum groups or dancers when we have had events. Right now with COVID, our activities are virtual. So we have had some guest speakers who have knowledge about the community, and also acknowledgement of identity. Again, because some of our clients have varied knowledge or experience with the Native community, we don't require a certificate of Indian blood. We are not funded by Indian Health Services, so you can self-identify, and that that's actually helpful for some clients because some clients may feel like they haven't been accepted within their tribal communities. And throughout all of this, we still provide day-to-day care according to departmental standard. So that means, you know, managing walk-ins, triaging crisis, managing clients. And again, we get a myriad of presentations. So one of the proposed plans for integration, this is something that we put together maybe about a year and a half ago, are to start out by obtaining community and clinical-based perspectives to aid in developing a strategic plan, create the infrastructure for an integrated treatment approach, utilize an advisory board to help with treatment integration, really look at the nuts and bolts of our program, which includes treatment planning, assessments, staff training, and working with the department to utilize traditional practitioners, and also coordinate efforts with other racial and ethnic groups within the Department of Mental Health. And I think one of the reasons this is so challenging is because other programs are really focused on access to care, serving clients, direct service, and they don't really include the cultural approach. Or they might serve one population. There might be an adult program and they only serve stable adults, like prevention and early intervention. So that creates differences in approaches as well. Some of the efforts we've made, again, on the clinical level, is continued discussion of integration efforts. We were having bi-monthly meetings, but we've changed it to monthly with staff to talk about cultural interventions. And this has involved different things, such as bringing maybe a proposed group curriculum to the table to talk about it, to see, you know, how it may or may not be culturally relevant or potentially harmful. It's included planning meetings or events for the community. It's involved looking at our treatment plan or looking at our documentation to see how it may be modified to be more culturally appropriate. So we've done a lot of work in these meetings, and we've also provided surveys to clients regarding what is it that they want. You know, we have provided activities, but if just because we as clinical staff think something's appropriate or this is what the clients want, we really need to hear from them to see what it is that they're needing. And at the administrative level, there are stakeholder meetings, which provide funding routes through MHSA dollars for one-time projects. This is the USCC that I was speaking of. Some of the projects which have been done with this before are advertising, like billboard advertising, commercial advertising of the Native programs available through the department. Conferences have been held, and now they're focusing on more community gatherings and discussions. One of the other pieces that plays a role in how we deliver services is Medi-Cal. The majority of our services are provided through Medi-Cal funding, which guides billing and service delivery. And also the vendor process, the research process takes months. If we did want, or we have had cultural speakers come in, and sometimes for them to get paid, it may take 3 to 6 months for a presentation, which can be challenging. Or if we wanted to do a research project, it can take 3 to 6 months just to get all of the administrative parties on board to sign paperwork or to be able to have a discussion to move these types of projects forward, because this isn't a research institution. And this is something, I'm sorry, my bar keeps popping up. This is an overall view of the environmental conditions which can be involved with cultural integration of mental health services. And I'm showing this because it's a larger picture of areas to consider, such as legal conditions. We, heard horror stories of, people maybe being hurt by someone who may, claim to be a traditional healer. Also, looking at the legal and ethical conditions of providing mental health services within a cultural context and what that means. Are we being effective as a clinical program if we're not including all of the components related to cultural integration? Other cultural conditions are the need to recognize historical factors which influence mental health conditions, and also acknowledge how the Los Angeles community is unique. Some economic conditions are funding of instructors. How do we pay them? How do we bill them? How can they be acknowledged financially for their services? And for services that may be non-billable, how does the department recoup time and money for service delivery? And then we have political conditions. It was like recently that Joe Biden, our president, recognized Native Americans in his speeches. And formerly, Natives have been an invisible group. Oftentimes people don't know that American Indians exist. I've even heard that in some of the presentations I've given. People don't know that there's Native people in Los Angeles. And other political conditions include the influence of clients and community members and local agencies serving communities and how they may influence the political scheme. Some external threats to cultural provision is the building structure. As I mentioned before, we don't have our own space. So space is limited for cultural activities. Our security we've had issues before with clients who were coming in who had a medicine bag because security wanted them to open that up. And, we had to explain to security that, a medicine bag is something that's been blessed. You don't open it. And so that kind of thing can be a challenge. Also, some of the internal threats, as a manager, sometimes managing, like looking at priorities. What is priority? Is cultural service delivery the priority, or is making sure our direct service numbers are where they need to be? Is that the priority? And also job demands. If we have a client who comes in who might be Native, but he's homeless, we're not necessarily going to sit and talk to him about his Native tribe. We're going to make sure his basic needs are met. Does he have a place to stay? Does he have food? Is he suicidal? Or, does he have other needs? So sometimes those needs take place before the cultural discussions can take place. Some of the factors which can lead to success are ensuring that staff continue to be involved with this process in these discussions and sharing their ideas, ensuring that we continue to assess what it is that clients want, what it is that they need, and surveying them. and also overall approval by the larger administration. Some of the controls that we have are, continue to meet staff and clients, evaluate what is or is not working, consistently look at procedures and how we may modify them, and also remaining transparent. Transparency with our clients is important, and also upper management. And the goal overall is to provide culturally relevant services to the populations that we serve. So this is just an example of some of the different components which play a role in the work that's being provided. And looking at or talking about some of the community and clinic-based perspectives, we have been able to have focus groups. I will talk about this later, but we created a garden, which was one of the clients, she persisted. She wanted a client garden. We created a garden, and with her ideas, we developed a potential research protocol on using gardening for health to help manage depression and also diabetes. So we've been able to conduct focus groups with clients and clinical providers and cultural leaders to look at how this may or may not be effective. Assessments, we've provided some surveys to clients to see what it is that they want, what it is that they need, and also continually assessing staff. What do you think clients want? What do you think they need? What are you able to do to help see this through? We are also in the development of finalizing our community cultural advisory board, and this will be composed of elders, leaders, volunteers, again, for the purposes of providing feedback and direction for integration, and also to help in the documentation, sharing some of the documentation, maybe asking clients, how would you feel if you were asked about this or not asked about this? I've seen some research that says, when people are asked about their tribe, they feel better, they feel more comfortable, especially if receiving care. And also, our client advisory board has assisted in the planning of different mental health and holiday events. So that's always nice because they get to share what it is that they want, and they get to participate in the activities. And some further infrastructure, we are continually looking for a building. We did have a building that AICC was supposed to move into, and I found out yesterday that the CEO was not able to negotiate with the landlord. So it looks like we're going to continue to be in the same building that we're in. I haven't yet broken the news to staff, but I know it's going to be a disappointment to staff and clients. And so what we do is we try to, make the space that we do have welcoming. However, we would like to find a place to maybe have a sweat lodge or other cultural events and practices. We have had our events at different parks, which is always nice, but it'd be nice to have our own space, and continue to establish protocols for integration of traditional healers, and also understanding the funding mechanisms and how we can use these to sustain an integrated approach. And also, one of the goals that I would like to do, especially in the Masters of Public Administration, is conduct program evaluation, a formal evaluation, so that this can be presented to the administration in the department so that they can maybe gain a fuller or more comprehensive understanding of what is needed. This is some of the, art, like we have, this is a poster, but this is a painting that one of our clients did during one of our events. One of our staff drew this design, and then he cut it up into a bunch of different squares. And during one of our events, clients were able to paint a square. So, this is just kind of a representation of the comprehensive, the clients that we serve and just where they come from. And this helps, sometimes when people come in and they see posters of other Native people, it helps, you know. And as I mentioned earlier, we are accepting of self-identified Native clients. Our staff, we've conducted more training so that people are aware of what it may mean to work with someone who's American Indian and Alaska Native. And we've also had t-shirts, usually annually, which reflect culture and healing. And again, this kind of helps like create, you know, a sense of community and belonging. And addressing culture in treatment sessions. This helps to address culturally relevant experiences and really understanding, you know, asking clients, where are you from? Are you from, let's say, New Mexico? You know, did you grow up in Santa Clara? How long have you been in Los Angeles? How do you identify? Looking to understand rapport or to enhance rapport and understand the client. Talking about trauma. A lot of our clients have trauma. So how has that impacted their mental health, and what can they do to maybe change some of those behaviors or, you know, thoughts or beliefs? You know, what can we do on an individual level to help break the cycle of trauma? And also, you know, by doing that, we provide our clients an opportunity to share their experiences in a meaningful way that's comfortable to them. Also doing community outreach. This is two of our staff who did outreach at one of the local community colleges, because again, you know, in order to build trust and establish rapport with the community, they need to see you, they need to be able to talk to you. And so that's one of the big pieces with serving our Native population. However, with COVID, it's been somewhat challenging because we're not really doing things face to face. And also, you know, sometimes staff get burnt out on doing things on the weekend. Again, just, you know, assessing where clients are at, what level of acculturation, how do they identify? You know, I've read some texts that say when you work with a Native client, you should burn sage and have cedar. And I think, you know, for some people that might be important, but I know that like some of my family who are Native or live on the reservation, you know, they're like, my aunts are Christian. And I think if they ever went to a counselor and someone offered them sage, they might become offended and never return, because that's not what they need or want. So really being mindful of that and exploring that when we do see clients is important. And continuing to assess during the intake, you know, finding out about a client's tribal history. If some clients don't know exactly where they're from, we can help them. We can provide them with resources to gain more knowledge on their background and you know, help them learn more about their culture, and really assessing their experiences in urban reservation and tribal lands. And one of the other pieces that we're working on is, you know, we have an electronic record system. So just working to be able to enter tribal data. You know, if a client comes in and says that they're American Indian or Alaska Native, to be able to have a drop-down box or something where they can click on Santa Clara Pueblo or whatever tribe they're in, so that that data can be in the record, which again helps to account for the Native Americans that we do serve and where they're at. And also, you know, based on that data, we can target our interventions and where we provide services. So this is something we're working on with our quality assurance and clinical informatics department. Also look to provide treatment planning, which can facilitate healing for our clients. You know, what are the clients interested in learning about regarding their culture, or what cultural activities or practices would they like to participate or have they participated in? Sometimes I've had clients who say, yeah, you know, I used to do this, I used to dance, or I used to engage in a cultural practice. You know, my aunt taught me to pray, but I haven't done that in a while. So even working with clients to help get them reconnected to that. And, you know, again, with cultural treatment planning is how do we track and assess culturally centered treatment goals? This isn't something that is in our electronic record system, you know, for purposes of Medi-Cal reimbursement. Culture is not necessarily something that is needed. Medi-Cal wants to see that there is a medical necessity and our clients receiving services because they have a condition that requires medical treatment. Although we can include culture, it's an additional piece, and cultural integration is important to our staff. But the other thing to consider is if you have 2 or 3, 4 treatment plans you're doing in a day and you have an hour session, sometimes you just get the most basic information and you might leave out the cultural piece because you have other work, you have other clients coming in and other things that are needing to be done. So those are some of the challenges. Some of the cultural healing groups that we have had, again, pre-COVID, we have had drumming groups, a White Bison cultural recovery group, healing through cultural arts, storytelling. We have domestic violence and healthy relationship group. We've had walking groups. This is a group that I help facilitate with a friend of mine she's been sewing for, I don't know, like 60 years. And we helped, you know, worked with the women here to make shawls and ribbon skirts. And it was really cool because, you know, some of the women had never sewn and they didn't know, but they were capable of doing. So it was really nice to see the work come together and to be able to provide this care. And we're looking to see how we can continue to do some of these things. We do have art groups, but now that, you know, cases are kind of going up again, the department was talking about opening up, but I'm not sure what that's going to look like. You know, it's always kind of a back and forth. Some of the other evidence-based practices that have been used in the department or in our program are, we've had training on Mending the Circle, which is a cultural adaptation of trauma-focused CBT, White Bison, which is similar to 12-step methods from a Native perspective. Our team has been trained in DBT and look to adapt that to Native populations. And we've also had some staff who are trained in healthy relationships from the Native Wellness Institute. And one of the other initiatives the department has moved toward is using American Indian health promoters to go out in the community and talk about mental health concerns and how to get help. This is a picture of our garden, and some of these pictures got blurry. But prior to COVID, we did have a garden. We would have monthly events. This was driven by the clients and the client advisory board. We planted traditional foods and plants like pumpkin, squash, beans, corn, sage. And it was really fun when we had our events and we could go out and be in the garden. And our Gardening for Health Easing tradition, which we did the focus groups, it incorporates gardening, diabetes education. And so now we're in the process of writing all of the results up of the focus groups so that we can get this published and help to kind of form a curriculum or share with the world how gardening can help treatment of depression and diabetes, you know, amongst an urban Native population. This is one of our mental health days. In May, it's Mental Health Month. So every year we would have our mental health events and we would have dancers. Some of our staff would dance, or we'd have community dancers, and we'd have our TP. There's Mr. Saginaw Grant, our drum circle. And, you know, this was really a nice opportunity to get together, for clients to meet one another. You can see back here, we'd have other organizations come and, do outreach to the community and promote their services, and also give our clients an opportunity to get connected with other service agencies. So this year we had to do our event virtually, but we're hoping eventually we can, maybe have a powwow for our clients and just expand this program and make it larger and better. So some of the challenges of providing culturally centered care are clinical demands. Working for the department, there is a lot of clinical documentation which needs to be done. Things are time limited. Addressing emergent needs of clients. If you have a caseload of 50 and 10 to 15 of your clients are homeless, or they're in domestic violence relationships, or they have, they're about to be evicted, legal issues, those tend to take priority. And again, that the basic needs are where the focus may be. We also want to continue to focus on collaboration with our team and practitioners, and just become more familiar and more comfortable with incorporating culture into our sessions. We have had more trainings for our staff to enhance their knowledge. We've had trainings on the Two-Spirit population. Elton Naswood was able to provide us a really good training. We've had trainings on the relocation within Los Angeles, alcohol use, trauma, and acculturation. And we've also invited other staff to share about their tribes. We had a training on the Huichol and Cora tribes, which are indigenous to Mexico. So we want to show our staff and our clients that it's important to, respect and incorporate all cultures and understand all cultures. Some of the challenges right now during the pandemic are our services are primarily virtual. If needed, we will see people in person, but we're not able to have the large scale community gatherings that we're used to or we've enjoyed. This has included increased isolation with our clients and also some of our staff. Our garden, we haven't been out there, so it's like it's pretty much gone. We need to go back out there and pick it up. And also, just the stress that clients are dealing with of managing this pandemic, and also the staff stress, and also just numerous transitions that are taking place within the department, which kind of trickle down into client care. So in working with partnership with the department, some of the things that we're addressing is how to incorporate some of the culturally relevant enhancements into the clinical documentation. Our psychiatrist, Dr. Dan Dickerson, is going to be involved with our electronic records council. So that will give him an edge and to be able to talk about why this is important and relevant, and not just to the American Indian community, but to all communities in Los Angeles. Working to understand more about billing and coding for traditional practices and cultural activities. Finding ways to maybe certify or hire traditional healers. I know some clinics, I know like in Alaska, they have an actual traditional healer and you can see them just like going to the doctor. So being able to get on that level is ideal. And also continuing to collaborate with other racial and ethnic groups within the department. And we have discussed the need for tribal identity and electronic records with the underserved cultural committees to get their feedback and to acknowledge the need for diversity. Other challenges may be malpractice, again, like thinking of horror stories, and I know we're not supposed to think of the worst thing, but if someone was hurt, then what? Then what would happen? And also resistance to change, institutionally and also among staff, again, looking at documentation. If it's one more thing you have to add, that can create stress. And also really just looking at the differences in values, Native values are quite different than the Western values, of numbers and data. So how do they work together? And again, this is a continued and ongoing process. We've been doing this for years. We will continue to do this. And some of the things that we're going to be planning will be Feast of Resistance for November, winter solstice events, which will be virtual, really looking at how to integrate documentation, and also how to manage our direct service and timeliness and our departmental standards while prioritizing cultural work, working on program development and evaluation, getting our research projects out there in the world and published, and really working to continue to hire more clinicians and staff with either personal or clinical background in Native American culture. So that feels like a lot. That's what I have. So thank you all for being here. I don't know if anyone has any questions or thoughts that you'd like to share.
Just give everybody a few minutes to go ahead and ask any questions that you may have. You can go ahead and unmute yourself, or if you can't do that, then just go ahead and put it in the chat.
I'm curious where other people work and how some of the cultural integration happens in your sites.
I have a question, Dr. Cain. First of all, I really liked your the chart that you had, the environmental conditions analysis chart was really cool. But I'm curious if you could share maybe some ways that you have presented to your advisory board, ways of incorporating cultural integration into your programs when you guys have multiple tribes within your service area.
Some of the feedback or some of the ways that we've thought about doing that was maybe to have like maybe one month we might have someone talk about the Pueblo culture, or maybe someone talk about the Navajo culture, because that is one of the things that we do bring up when we are having events, is that, you know, this might be the way that a particular tribe or culture does it, but it doesn't necessarily mean that it's familiar with other tribes or cultures. So we do try to acknowledge that. And I think that's important too, because being in an urban area, there tends to be, you know, like the pan-Indianism, and, you know, this is what we do, but it's so different, and it's really important to talk with clients, and even in these larger scale events, to see what it is that they want and what it is that they need, and how we can acknowledge unique tribal experiences. So, thank you for that question.
I have another question. You had mentioned that whenever you guys do intakes or meet with clients, that you ask what traditional practices they engaged in or used to do or currently do, or what they would like to get back into. Do you guys meet regularly to talk internally about like what those things are and plan out how you're going to incorporate, or how do you guys decide what?
Yeah, we've been meeting, those are like the cultural integration meetings that we've had to talk about what clients have wanted, and to talk about how we can incorporate that. We have had different groups and activities, you know, like sewing or beading. And then what we found is that clients wanted these groups, and then when we had it, they didn't show up. So, you know, really trying to find a way to talk with clients and staff and say, okay, how do we do this? Or even if it's on an individual level, you know, if a client wants to get connected with this, then we might bring it up in the cultural advise, or, you know, our staff meeting, to say, okay, how does anyone know who in the community might work with a client on this particular matter, or or can we bring that person into the clinic so that we can get their knowledge or experience and share it with the clients. So there's the monthly meetings, and then the meetings that we'll be having with our client advisory boards to bring that up. And then just really gathering the data and bringing it back to the drawing, the drawing board, and evaluating and moving forward.
What age group do you feel like you're most reaching right now?
Well, I would say right now we're probably reaching more of the adults. However, we do have some cultural art groups for the children and the families. And one of our community workers, his name is Raul Garcia, and he's worked in the community for a while, and he has an art group. And so we've been able to reach children and families. And what he does is he has them RSVP as to whether or not they're going to attend the group that week, and then he'll deliver the supplies, whatever the supplies are, and then virtually, like this, the art group is being done. We do also, reach clients on an individual level, but again, some of that tends to be more of like the therapy or helping them adjust to trauma or transition. Helping them adjust to school, especially now, talking like about children. But yeah.
And what about advertising? How do you get the word out, or how do they know about you?
We, prior to COVID, we used to go to events like powwows or other community events. We have had like a larger advertising. There was a commercial that was out. That's actually one of the challenges, and I'm thankful that I'm able to present today, because I'm able to present to a different group of people who may not have known that our center was there. So really, we're really also working to connect with other agencies like other agencies within California to advertise our services. And we've sent flyers to Indian Health Service, like for different events or hiring, so that we can get the word out. But that is a challenge. We're not allowed to have a Facebook or Instagram page, and I know a lot of advertising can be done virtually. So we're trying to figure out ways to get that out. But a lot of advertising also happens like word of mouth. We've had clients come in who say, oh, you used to see my sister, or we've had clients who aren't Native, but, they know someone who was Native and they want to come work with us because the Native client talked about the services they received. But that is one of our areas for growth, I would say, is advertising and getting the word out about our clinic and the services we provide.
Thank you for that. It always seems to be a challenge for everybody across the board as far as advertising.
Mm-hmm. Yeah, I don't know if there's any strategies that are used or anything you guys have seen which is effective.
So we try the social media a lot, and just like you said, word of mouth and things, but just getting that word out there sometimes.
Mm-hmm. Yeah. Be a challenge.
Does anybody else have any questions?
Through our THPS department at USET, we have like our strategic plan is divided into different committees, and one of them is like our recruitment committee, and we're doing like different strategies that we want to implement or incorporate that might help with that. Would you be okay if we shared your information?
Totally. Definitely.
Hoping to we're hoping to partner with different like Native colleges and universities, but then also other programs like College Horizons or American Indian Graduate Center or anything like that. And then through internship programs, because it is important to establish those partnerships anywhere in the country, because we have, you know, everyone travels and relocates for school and work for, you know, so it's important to have that, but I would like to include your information in that.
Yeah, definitely.
Yeah.
And it's also nice, you know, for other Native people to be able to know, like, oh, there's a Native organization. Maybe you're not a mental health clinician, but maybe you can volunteer or attend some of our events, or, you know, be a part of something. And we do have relationships with some of the universities, and we're able to get different interns, like graduate level and bachelor level interns, which has helped us recruit some of our staff so that we are able to get Native staff. But it is a challenge, you know, and one of the other processes, or one of the challenges is it can take anywhere from like 4 to 6 months to, like, once you're hired, to actually start. So if you're someone who's looking for a job and, you know, you need a job right now, are you going to wait? Or do you have the opportunity to wait? You know, so sometimes that's difficult as well. We have lost some staff who have taken other jobs or positions just because of the time that it takes to process their hiring paperwork.
Oh,